Welcome today to your pelvic health after cancer treatment. And I could add after and during cancer treatment to that. My name is Linda Muffich. I'm a physical therapist. I'm the owner and operator of a small private practice clinic in Overland Park, Kansas. The name of my clinic is Fem Focus PT, Fem for feminine, because I do specialize in women's pelvic health issues. But I do have experience treating men, and currently in my caseload, I do have several male subjects with pelvic health issues that I'm treating. Talking with the guys, I just tell them, you know, when you come to my office, it's going to be real pretty and nice soft colors, and you're going to see pictures of women on the wall. And they say, that's fine. I'll even wear a dress if I have to, if you can help me. So I've been doing this work for about 22 years. When I explain to people, when they ask me what I do, I say I'm a certified, I hope you can all see my arrow, certified pelvic rehab specialist. And they kind of look like, what does that mean? So I like to tell them, looking at our beautiful picture here that Gilda's Club found for me, Gilda's Club found this great pelvic picture. I like to say to people, like when they roll their eyes and say, what's that? What do you do? That I do everything from below the belly button to above the groin, which is basically, you know, the anatomy of the pelvis. And then they kind of roll their eyes and go, oh, I think I know what you're talking about. So we are going to talk about everything below the belly button and above the groin today. After our talk today, if you realize that someone like me could help you with a pelvic problem that you're having, I'd love to see you as a client or a patient. But if you are looking for others closer to your area or your insurance, do ask if you're looking for a pelvic therapist if they have their certification. When you're working in this area, you do want someone who's been there, done that before. And certification is not required at this time, but it is preferred. So do know to look for someone who has the level of experience to be certified, okay? What is pelvic health in general? Some of you might have joined today just to find out what pelvic health means. Now you know the anatomy and where it's at, below the belly button and above the groin. What does pelvic health mean? We're probably more commonly heard of heart health or bone health. And when I say those things, you know what I mean, because there's been a lot of research and a lot of education to the general public to know what is healthy for your heart or what's healthy for your bones. And it's all that information has trickled down to the general public. If I asked all of you, tell me one general fact, a medical fact that you know that is healthy for your heart, you could probably answer, keep my blood pressure under control, do aerobic exercise to get my blood pumping, watch my cholesterol, decrease my stress, decrease my smoking. As the general public, you now know all that information, what's heart healthy because of the years of research. In terms of bone health, what's healthy for your bones? You could probably already tell me, eat lots of green leafy vegetables. They have a lot of calcium in them. I'm supposed to take vitamin D. I'm supposed to do weight-bearing exercises. When my foot hits the ground, that's going to stimulate bone growth. So those are already very common types of health, heart health and bone health. If I asked you in the audience, can you give me a general fact or general medical knowledge that's good for your pelvis? A lot of people would kind of go, I don't really know, because this is an area that houses three main organ functions: the urinary or bladder, the colorectal organs, and then the reproductive organs. And those kind of intimate kind of processes, and so we don't really talk about those a lot. But wait till you hear how common it is to have pelvic health issues. And I guess the point I want to bring home to the audience today is, let's start talking about this. Let's come up so that everybody knows general knowledge. Hey, I have to do this for my bladder, this for my colon right now, and this for my reproductive system, so we can keep ourselves healthy with self-care and exercise. So we're going to be talking about bowel, bladder, and sexual health issues today. Why is a physical therapist talking to you about this? And Anita, I lost my screen. I can't see myself. So if you're listening, if there's a way to get me back so I can see myself, that'd be great. But otherwise, I'm going to hold up a model of a bony pelvis. So therefore, I can't see if you can see me. But you see it in the picture as well on my PowerPoint slides. But I am holding up the bony. Oh, thank you, Anita. Yay, now I can see myself holding up. So here's my model of the bony pelvis and the red skeletal pelvic floor muscles. Okay, so the pelvis is a very muscular area. When you layer the muscles on the bones, you've got the pelvic girdle, and just the word girdle, hearing about that, just makes me think, let's hold it all in, let's keep it strong, ladies and gentlemen, because this is where we get our strength for movement from. Our pelvis stays strong and stable, and then we move with our arms and our legs. So highly muscular, and physical therapists work mostly with muscles. That's why I'm talking with you today. And then also, you can see on my PowerPoint and here, I'm dipping the pelvis down so you can see the pelvic cavity, the circular, almost bowl-like structure that the pelvis makes up. So the bones and muscles together make up the pelvic bowl, and inside that bowl are those three organ systems: bladder, reproductive system, and bowel, colorectal system. And this is a pretty much a scale model of a human pelvis. So that's a pretty small area. Things have to fit in just right. So nowhere else in the body do the muscles, bones, and organs have such a close relationship. So even though we're going to be talking about organ functions, we can't keep out the muscle function. That's why a therapist is talking to you today. And then also, when you talk about general health, like that heart health and bone health, all health, general health, is going to include some form of exercise. For heart health, it's going to be aerobic. You got to get your heart rate up so that blood can pump. For bone health, it's going to be weight bearing. You want your foot to hit the ground to stimulate calcium to go in your bones. For pelvic health, the exercise we're going to talk about mostly is pelvic floor exercises, or what most people know of as the Kegel exercise. So we're going to be talking a lot about that. So physical therapists are experts in exercise and self-care. You're going to spend an hour to an hour and a half one-on-one with me, whereas when you see your doctors for follow-ups, you may get 15, 20 minutes. They're really emphasizing, let's, ask all these cancer questions, but I'm not sure if they're going to get down to simple things like, how's your bladder or how's your bowels? So physical therapists are experts in exercise and self-care. That's why I'm talking to you today instead of someone like a colorectal surgeon or a urologist or something like that, okay? What are these pelvic health issues? What are the problems that you can have an unhealthy pelvis? I've listed here the medical diagnoses that are considered pelvic health problems. And I put the medical terms because you might hear them from your doctor, you might hear them from, even Gilda's Club, and I just want you to know that put those in the category of pelvic health. So urinary and fecal incontinence just is loss of bowel and bladder control, having accidents, which again, very embarrassing. We usually don't talk about it, but we need to start learning how to understand and start to care for ourselves. That's a storage, those are storage problems. You can't store your urine in your stool, you're having accidents. But there are people who have what's called bladder, or it can happen to the bowel, urgency and frequency. That's technically a medical term, meaning you're not having accidents, but you're just going all the time, either one of those. And the urge to go, bowel or bladder, is so strong that it doesn't compare with the amount of stool or urine that you have in there. So urgency frequency is a problem. You can have storage problems, and then you can also have emptying problems. Some of the emptying difficulties, like if you have trouble for some reason, it doesn't seem like you can empty your bladder, or the stream is different, it's slower than it used to be. That could be what's called a voiding dysfunction, a trouble emptying the bladder. And then I think we are all comfortable, or we do have heard the term constipation, which is difficulty evacuating our bowels. Another pelvic health problem is having what's called, the medical term is a prolapse, or basically what that means is an organ is dropping. This is more common in women, and women can have bladders dropping, uterus, rectum, urethras, or other things. Men, it still happens too. They can experience rectal prolapse or urethral prolapse. Remember, we talked about the 3 organ systems housed in this small cavity, and then the bowl is made up of the bones, but the bottom of the bowl is made up of muscles. So if those muscles get stretched and weak, that has a tendency for the organs to fall in the pelvis. So that's a pelvic health problem we'll be touching on. And then the 2, we said we were going to talk about bowel, bladder, and sexual problems. The last 2 on this list are sexual problems, sexual dysfunction, something's not working right. Dyspareunia is a medical term. It means painful vaginal intercourse for women. And then for men, erectile or ejaculatory dysfunctions. You've seen the commercials for Viagra. And then you don't see a lot of commercials for dyspareunia, but both of those sexual dysfunctions, male and female, are high in the category of during and after cancer treatment. How common are these problems? The next 3 slides, I will just give you a prologue. I call them my Debbie Downer slides, because when you start hearing the statistics of how common these problems are, it's almost like, oh boy, I'm gonna get this. This is really bad. I didn't know it was this bad. It gets more hopeful after these 3 slides, just bear with me. But I did want to give you these pretty astonishing statistics, because it just goes to show you that it's so common that we need to start talking about it more. We need to start talking to our physicians about it, advocating for ourselves. Hey, I'm in cancer treatment, I'm fighting the cancer, but I also have this problem, which is a big deal in my life. It's a quality of life issue. And how do I deal with it? What can I do for myself? So again, don't be devastated by these statistics. I'll be able to tell you a little bit about, self-care and doing exercises to strengthen this area. But as you can see, this slide is all about women, and I do have a slide all about the incidence for men as well. Just hang in there. But 1 in 4 women suffer from a pelvic floor problem. So we talked about pelvic health, and then the pelvic floor is all muscular. So just think of it, 1 in 4 women has something going on with these muscles. And I think that's just because we do bear children, along with getting cancer and other things like that. So the statistics at the top are for women in general, not necessarily cancer related, but you can see how frequent urinary incontinence, bladder leakage is the most common pelvic health problem for both men and women. So most of the statistics are for that. If a woman needs a hysterectomy, and many times for cancer treatment, that's the cure. If it's uterine cancer or cervical cancer, let's take it out. There's a high percentage of women who therefore later will have those organs starting to descend because there's more space in there. Right now, 1 in 4 women of any age, of any problem, cancer or not, will have pelvic floor, but look what's estimated in 30 years. It's predicted that 1 in 3 women will have trouble with at least the muscles in this area. The next few statistics are specific to cancer and specific to breast cancer. We are in a pandemic with corona, but there is also an epidemic of breast cancer. Women, young age, in their 30s, 40s, 50s, they're getting it. Many are survivors. They're surviving, they're fighting, they have years ahead of them, they have a full life to live. So, we need to know, those women need to know that if they're breast cancer, they fought it, they're okay with that, they might later on have problems in the pelvis. So the statistics for that are devastating, but again, we will be hopeful here in a few more slides. 50 to 70% of breast cancer survivors will experience one or more genital or urinary symptoms. And that study was done just a few years ago. The link here with breast cancer is estrogen. So when you lack estrogen, and sometimes when you're suppressed with your estrogen, even more than a natural menopause during cancer treatment, a lot of women are figuring, okay, no estrogen, can't have it for the breast. I'm going to experience some vaginal changes because estrogen and vaginas go together, but they don't understand that the urinary system, the urethra, is highly estrogenated. So when they're depleted with estrogen for breast cancer, there is a connection to your bladder, okay? And then also look at the high percentage having sexual dysfunction. Again, that's the vaginal tissue has changed. This statistic, which is already 10 years old, I think it's a little better by now, but less than 50% of those women who after breast cancer are experiencing that get the medical treatment for it. It's getting better. There are screening questions that are being done in doctors' offices. But again, the focus may be on, all the cancer questions, and then the bladder and the bowel and the sexual health might get left by the roadside. So please advocate for yourself if you're having issues in this area. Talk to your physician, tell them what you're experiencing, and you will be one of these statistics, but you'll also know that there are ways of self-care and help. The last statistic in this slide, prior, this was really heavy on bladder and breast cancer. I felt like I needed a statistic for the sufferers of like colorectal cancers, because that's in the pelvis as well. So if someone is suffering from colorectal cancer and has procedures and treatment done for that, very necessary, it might be tumor removal, it might be radiation, there's about a 50% chance that they will have trouble with bowel control after. FI means fecal incontinence. Lo and behold, they might also have bladder incontinence after, because how close those organs are. And then 14% of those who undergo colorectal cancer treatment, even if they had no bowel or bladder problems prior, will end up, 14% will have both urinary and stool control problems. So that's kind of just an incidence for that. The next slide is more for our men, if there's any in our audience. How common are male pelvic health problems specific to cancer treatment? And the most specific, most prevalent cancer in the pelvic region is prostate cancer. So lots of thousands, hundreds of thousands of men are having prostate removal because it's necessary for cancer. What does that do to their pelvic health? Most of the studies for males after prostate procedures come from the University of California at Irvine. So if anybody's interested, you could look them up, lots of statistic. Having bladder leakage problem, urinary incontinence, it is the most #1 prevalent complication after prostate surgery. When they handed out lifestyle questionnaires to males after prostate surgery, what's the most devastating on your lifestyle? It's not erectile dysfunction, it's actually bladder control problems. I think the men that I've treated, women are more used to having changes in this area from childbirth, and we deal with it, we get better. It's just another part of being a woman. I think when the men that I've seen, it's devastating. It's like, gosh, I have to wear diapers, I'm like a baby again. And then also for men, the time frames, like when will they get better in these pelvic health issues? I think for men, it's kind of a roll of the dice, because look at this. Different studies say after prostate surgery, if you have bladder leakage, it could take anywhere from 6 months to 18 months for incontinence to improve. I have seen males get dry in 3 months, and then I've seen males 2 and 3 years later who are still leaking. So I think men have the right to be concerned and worried, because it's kind of a roulette wheel or a turn of the dice. What part of the statistics am I going to fall in? How soon am I going to get better in this pelvic health problem of bladder control? A lot of factors for men make up how or why or how much their bladder leakage is after prostate problems. All the list here, if there's a male who's got bad bladder problems before surgeries, he's got a larger prostate lesion, he has to have more extensive surgery, you have these comorbidities, if your surgery causes a lot of swelling that takes a while to calm down, all those things might tip a man into having more severe and longer incontinence after prostate surgery. Moving down on this slide, we're almost through with the Debbie Downer slides. Hang in there. Male sexual dysfunction, again, a roulette wheel turn or a dice roll. Different studies say 14% of males after prostate surgery, and then some studies say as many as 85% of males will have sexual dysfunctions, erectile, ejaculatory. They found that the incidence, the severity, and the type depend a lot on how old the man is, especially if there was radiation. He needed radiation to that prostate. You're more likely to have sexual dysfunctions and the more radical procedures. Though interestingly enough, there is that robotic prostatectomy, and I think they're doing hysterectomies robotically now too. At least with the robotic prostatectomies, they're not finding any significant difference in men coming out of those without sexual dysfunction. Does that make sense? So a less invasive surgery may not mean that you're spared this kind of dysfunction for men. Okay, one more statistic slide, and then we're on to more hopeful thoughts. How specifically do cancer treatments cause these pelvic health issues? They do it through two routes. One is a direct route and one is an indirect route. So if your cancer treatment means you have to have a surgery, that's a direct route to these pelvic organs and the pelvic muscles that are so important to pelvic health. Surgery in here can change spaces if you take out an organ. It can cause scarring, and so sometimes scarring is the problem. Organs get scarred, and that can cause a problem. Anytime you open up the abdominal cavity, the pelvic muscles, no matter what surgery, even if it's a gallbladder surgery, non-cancerous, appendectomy, non-cancerous, anytime this whole area becomes weak. So that's how surgery directly affects pelvic health problems. If your cancer treatment needs radiation, that's a direct effect on pelvic health because they're aiming that beam at the cancerous tissue. But the tissues around can be affected by both the swelling that's caused, pressure from swelling after radiation can be put on organs and nerves and cause pelvic health issues. And then also, they're pretty much beaming the cancerous tissue and heating it up with radiation, but the tissues around can have some heat effects, and they actually change. The tissue is less pliable, it's not as strong, and some of those support problems can show up after radiation. So those are direct methods of pelvic health problems coming from cancer treatment. And then the indirect methods, there's two. The chemotherapy, you could see here, you might get it IV or other methods, but they want those chemicals to go around your system to get to all the cancer cells. But the bowel and the bladder are storage chambers for the body. So after these go around your body and kill all the cancer cells, they concentrate and collect in the bladder and the bowel. And so they're pretty caustic chemicals. So they're pretty much like salt in the wound of your bowel or your bladder. And the most common problem, you can get like chemo bladder or chemo colon, is the inner lining of those organs gets so irritated that you end up with the urgency and frequency. It's like bloodshot eye, but it's inside the colon or the bladder. So you feel like you gotta go, you're going all the time. It's bladder urgency frequency, and then colon urgency frequency would mean frequent diarrhea after chemotherapy agents irritate those organs. And then hormone suppression. If you have a reproductive cancer, like breast cancer, other cancers, and they put you into hormone suppression, those changes in the area down low are usually more severe than a natural menopause. So that's an indirect method. We are through with the Debbie Downer slides. Things can be done. And again, the general public needs to know what pelvic health things they could do for self-care and helping on the road to healing from these problems. So we're going to turn to each of these problems specifically, and then I'm going to start talking about the pelvic floor exercise and the Kegel and other general medical knowledge that you need to know to help yourself. Bladder and bowel control problems are the biggest pelvic health issue. So right here, I'm just going to talk about that there are different kinds. The two main kind of bladder and bowel control problems are called stress and urge. On the right, on the right side, you see this lady here. It looks like she's about ready to cry, but it's not emotional stress that we're talking about. She's about ready to sneeze, and good thing she's covering her sneeze with her handkerchief. When I first saw this, I was like, is she crying or is she ready to sneeze? So I took it because it's questionable which is which. Well, we're talking about the physical stress of a cough or a sneeze. Achoo! Those are a lot of changes in your respiratory pressure up here. And then when that changes, it puts pressure down low. So your diaphragm is doing some funky stuff with your coughing and sneezing and puts pressure down low. So coughing, sneezing, laughing, shouting, and if you have weak pelvic region, you can leak urine with those activities. So stress incontinence. And then also up here, it's this physical stress of movement. If you're jumping jacks, squatting, exercises, bending, lifting, that's another form of stress incontinence. When you do that, the physical stress goes down into the pelvis, and then the muscles are weak, and out comes the urine or stool. Urge incontinence is over here on the left. Here's another questionable picture. Is she running to the meeting late, or is she running out of the meeting that went over because she's got urge incontinence and she can't hold? If she stays another second to listen to the boss, she's going to have an accident. So urge incontinence is this almost instantaneous. Your brain feels the urge and then all of a sudden it's coming out. So that's urge incontinence. And believe it or not, you can have a third form of incontinence, which is called mixed, which means you have a little bit of stress and a little bit of urge. So it's kind of a double whammy. Pelvic floor Kegel exercises, because remember, muscles have a lot to do with bladder control. And also physical therapy can help with this. We're going to talk about the Kegels. And when we talk about the Kegels, I'm going to assume most people in the audience, if they're mostly primarily women, have heard about Kegels from having babies. Dr. Kegel was a gynecologist in the 50s and 60s who saw enough babies stretch these pelvic floor muscles that he said, ladies, if you don't exercise these, contract and relax voluntarily, you may have pelvic health issues or bladder bowel control issues. So the exercise is about 60 years old. And there's probably 60 or more methods or instructions on how to do it because it's been around for a while. So Kegels, believe it or not, can be very confusing. And that's why when I talked about a physical therapist helping with these problems, some people need help with their Kegels. And we'll get more into why that is. Right now, I just want you to meet your pelvic floor muscles. So above is the male model. I'm hoping you can see my arrow, but here's the bony pelvis. This is the pubic bone, and then we've got ligaments, we've got the tailbone here, and then between, and these are the sit bones, what you're sitting on. So between those bony and ligamentous structures that form a diamond, remember that diamond, because that's going to be important when we talk about how to do Kegels. you have the pelvic floor muscles. Above is male. This is like the base of the penis and the scrotal sac with the testicles. Down low are the female pelvic floor. So look at that same bony diamond that you have. That's kind of important because we'll use that later when how to do your Kegels properly. And then inside the bony diamond are the pelvic floor muscles. And these are the bones you sit on. There's one sit bone, other sit bone. You have 3 layers of muscles in this area. You have nearly 30 muscles. Some of them are paired with a right and a left. And then some of them, like the sphincters, which is just a fancy word meaning circular, are in the midline of the body. And you only have one of those, one each. You don't have a paired sphincter. But other pelvic muscles, you have a right and a left. Pelvic muscles have 3 functions, and they're all start with S's. Sphincteric, which sphincter, again, is just a fancy term that means circular. So a sphincteric function are these sphincter muscles that tighten up and close off the rectum and urethra. They're the main muscles of continence or incontinence if they're weak. Another function is the support function. And actually, I think we covered that quite well. Here's the bottom of the pelvis, and then the organs are inside. And so the floor of the pelvis is supporting and holding those organs. So I think that's pretty clear. And then the third function is these are muscles of sexual function. Sex is kind of complicated. I don't claim to be an expert, but there's different phases of the sexual act. Like you have desire, arousal, erection, and orgasm and ejaculation. The role that these muscles play in sexual function is mainly during climax and orgasm. You get a reflex, you get aroused, and then orgasm is these muscles reflexively contracting. So just remember that, because we're going to talk about the difference between erection and ejaculation and orgasm later. So main sexual functioning muscles. These muscles are red skeletal, voluntary control, the same as your biceps and your triceps. So we have 2 kinds of muscles in the body. Red skeletal, we can control them. We have to learn how to control them. And then we have smooth white muscle that works on its own automatically throughout the body and throughout the organs. But these are red and you have voluntary control. You learned how to control them during potty training years ago. Think about it. You learned how to control your brain down to these muscles, which are the bottom of the spinal cord, the tailbone. So those messages that you learned in potty training, they go far from your head down to the tailbone. Think about it this way. We learned how to walk as infants and toddlers, right? We do that about between 1 and 1.5, but it takes longer to learn bowel and bladder control, almost 2 and 3 years. So just appreciate that, the connection from the brain all the way down. So if as adults we lose bladder control, it's not an easy process. It's a thoughtful, takes a while process. So remember that when we talk about why Kegels are so hard to do correctly. Since these are red skeletal muscles, they can vary in strength, they can vary in endurance, coordination, relaxation. They can get stiff and cause problems. And then this sensory awareness, they are the deepest muscles in the body. We cannot see them. So a lot of times we get visual input from where our bodies are in space. If I want to get my biceps stronger, I'm just going to, I can see it working and I can see it pumping. But if I need to rehab and get my pelvic muscles stronger, if I don't have a visual input, it might be harder to do. And I might not be able to sense what I'm doing. So again, red skeletal voluntary muscles, they weaken with age, they weaken with hormonal changes, they weaken with surgery, chemotherapy, disuse, and then lo and behold, you might have one of these pelvic health problems. So you do talk to your doctor and you're recommended to do Kegel exercises, and you might be given a written handout. Here, go home for this pelvic health problem and do these exercises. Or you might have read about it on your own and Oprah magazine or something like that. It's harder than you think because research shows, this research is one of the oldest research I've quoted in my presentation. It comes from 1998. Usually I like to have more recent research, but sometimes when we learn something, some things never change. And 1998 is when I started doing this work. And so the last 22 years, I have not seen this fact change. The fact is that they did a study and they gave people a written handout. Here, we want you to read this and do your Kegels for your pelvic problem. And then the other group, they had a person explain briefly, verbally, how to do a Kegel. And then they sent them home and they brought them back and they tested these pelvic muscles on a monitor. And we'll talk about the monitor because I use it too. And they wanted to see if through learning this way that they actually got stronger in these muscles, or was something else going on. And what they found was that 50% of people in this study did not contract these pelvic muscles correctly with just a brief verbal or written instruction alone. So when I was looking for pictures for this presentation, I just searched pictures of people doing Kegel exercises, and look what I came up with. I came up with an arrow going this way. For males, I came up with an arrow going this way. I came up with a picture of a female arrow going this way, and then look, you can, if you're a man, you can get a DVD, pop it in, and learn that way. But sometimes if these muscles have a problem already, you can't see them, you can't feel them, you need help. And that's where someone like me comes in. I end up being a professional Kegel coach, basically. That's what I do. A pelvic health physical therapist has ways to help you strengthen these muscles. And one of them is through a muscle monitor, and it's called an EMG, electromyograph. Many of us know an EKG, electrocardiogram, where they monitor your heart and you see heartbeats on the screen. Here, I monitor your muscles. This is a pelvic model on its side. It's a female, urethra, vaginal, anal. I put patches underneath the sit bone, underneath the bones. I can do this discreetly. People can still wear Depends or pads or clothing. I can do it discreetly. Some clinics use vaginal or rectal for male probes. I think that's invasive. It's quite expensive. If there's pain involved in those areas after a surgical procedure, I think I get just as good results from surface patches. And then you are learning through visual feedback. So this is an actual screen of someone doing a pelvic contraction, holding gas and urine, and then relaxing, taking them through 10 contractions, 10 seconds long. This is a pretty good screen. This is a pretty good run. A lot of times when people are weak, it doesn't look this good. But do notice the strongest one is the first one. Can you see how this is the highest peak? And then the peaks go down from there. So that's kind of a sign of weakness. So if someone's having trouble finding, feeling, working these muscles so that they can get better, something like this is really good to feed back and to show them. I have people who can't make the line move at all, and I look over at them and they're making like, I'm trying really hard. Why is the line not moving? And then we have to figure out, okay, evidently this connection from here down there, something's been lost, something's been weakened. We need to reconnect mind with body, and we need to find out what your body's doing. Sometimes people are just holding their breath, trying to squeeze, or other muscles might kick in. So these are reasons why Kegels are hard, but Kegels are something that if you learn them, you could do to keep yourself healthy in this area. Some people might need more feedback. So I've learned over the years of doing these talks that people like gadgets. So I'm throwing all these gadgets, I'm showing you these things, but truly to get a natural contraction, mind over body is great. When that happens, it's wonderful. And it's almost like the client's like, oh, I think I got it. I think I can go home and do these now. But some people need a little help. I'm going to show you the fun gadgets. Sometimes they're not so fun. Vaginal weights for women. There are comparable devices for males. These, in my opinion, are pretty high level. If you're really weak, these might strain you and that might cause soreness in the area. But as you get stronger, you might be able to stand up or have a weight in and move around and contract your pelvic floor and prevent leakage. Sometimes they're used for people who are really weak just to encourage that feeling, but the client is laying or sitting, so this doesn't fall out. But then they feel, if they're doing the right contraction, they could feel that they're moving that weight inside. This little device, you can all write this down because I know you're going to search it after this video. It's called a pelvic floor educator. It's a moderately priced, probably 30, 40 bucks. It is an intervaginal device. This part goes in the vaginal canal, and then this, they call it the indicator, is outside your body. So the pelvic muscles, especially that deepest layer, pull upwards and inwards because they lift up and in to support the organs. So if this is inside the vaginal canal and you lift up and in, this little indicator, you can look down and the indicator will point towards your feet. And then you'll know, oh, I think that's my muscle. I think I'm lifting. I want to get that support for my organs. So if you're holding your breath and, oh, I'm going to do this, and it comes up towards your face and it comes out, then definitely there's a coordination problem. And if you're doing Kegels that way for bowel or bladder control or organ support, you're actually pushing and making things more stretched out. So that's why these little gadgets can be helpful. I'd rather get a natural contraction, but sometimes they're needed. Think of it this way. Everything I'm showing you here is an intervaginal device. Think of it this way as well. We all have different shoe sizes. Our vaginal canals are not all the same size. And think of it this way, if you have irritation or pain or scarring, these devices, you might not even want to try them because they might aggravate those conditions. So as good as gadgets are and devices are, you have to have someone like me help you to decide, is that good for me, or which one, or is it worth it to try? Okay. So this is all techniques that I can use to help you learn pelvic floor contractions. But what good is if you learn it if you don't put it to use? So sometimes clients will get to me and I'll say, I'm going to help you learn how to contract these muscles so you have good pelvic health. No, you're going to do the Kegels with me? Oh, I do 100 of those. I read it. My doctor gave me a handout. And then I'll say, well, did you train yourself to do it right before a cough or a sneeze? Did you train yourself to do it before bending and lifting, before picking your groceries? And then it's like, oh, no, I haven't. Again, it's that mind body, it's repetition, it's practicing. So at this point in the presentation, I like to say learning good pelvic health and good contractions in this area is almost kind of like learning a tennis serve or a golf swing. Think about Serena Williams or Tiger Woods. When they were starting out and they were perfecting their golf swing or their tennis serve, they broke it up into little parts. They practiced each part, then they put it together, then they closed their eyes and visualized themselves, saw them in their brain doing their tennis serve, and all that led up to now they can do it in their sleep. Now it's an automatic process. So that's what's important about learning and doing Kegels, is not that you do them 10 in the morning, 10 in the afternoon. That's better than nothing, but that you train your body to use them during physical activities. So here's my male picture of how important it is during these activities to train your body, be thoughtful about it until you get to that point like Venus and Tiger, where your body's doing it automatically. And then it's like, oh, I don't have to do my Kegels. There it is. There's my body. I can feel it. It's doing it. So it is a learning process, and that's why some people need help with that. Let's go on. That's the exercises, and we are going to try virtual Kegels here in a few minutes, which will be fun. But remember, pelvic health is about not only proper exercise for the area, but self-care techniques. What has science learned that's good and bad for that area, and what can trickle down into the general population knowledge as to what's good and bad for my bladder and my bowel. So, for example, those people that have urgency and frequency, and every 20 minutes they get a signal to go, whether there's enough in the organ to begin with, they might need someone to help them with putting them on a bladder schedule, going by the clock instead of waiting for that strong signal and you're leaking already or having an accident. So someone who has a lot of urge incontinence or urgency frequency might come to somebody like me, fill out a bladder or bowel diary, and we would identify patterns and then put them on a schedule, kind of like potty training. If you learned it once, you could learn it again. So some people need self-care in the form of a bladder schedule. And then while they're having these urges and they're trying to hold off or wait till their time, there are some techniques to suppress your urge, like distract your mind, count backwards from 10, do 10 quick Kegels. Things like that can make that urge, even though it feels like, oh my gosh, I gotta run to the bathroom, it can make that urge lessen and go away, or at least you can walk to the bathroom and except run. So these are some of those self-care techniques that might be needed for good pelvic health. Along the lines of urgency, frequency, and urge incontinence, and think about that chemo bladder, that very irritated bladder because it had a lot of chemotherapy agents stored in it. If you're a healthcare provider, if you're experiencing chemo bladder and you've not been told to watch your foods and fluids that could make those sensations worse, you need a little bit of self-care education from someone like me. For example, if you have an irritable bladder or an irritated lining, putting a lot of stimulants like caffeine, coffee, make that worse. All the good things, you know, carbonation, the bubbles will make a chemo bladder worse. What else is here? Citrus, lemons and limes, that citric acid. So if your bladder is already irritated, someone experiencing an irritated bladder from chemotherapy drugs, something just as simple as just avoiding that for a while until that irritation goes away. If no one told you that, and you can do this yourself and find out by yourself, then you're ahead of the game. Also with bowel and bladder control problems, how much fluids do I get? There's a little self-help formula. Most of you have heard like 8-ounce glasses a day of water, which is a pretty good average estimate. That's 64 ounces. A better formula for how much fluid you should get in, although as you get up into the obese categories or mildly, moderate, severely obese, this formula doesn't work as well. But take your body weight, whatever you weigh in pounds, don't tell me, and take the pounds away from it and put ounces behind it. And then, you know, some people, the average build adult, 64 ounces may be right. Someone more petite or small, that might be overhydrating. And if you leak, that would be a problem. Or underhydrating. So that's a good rule of thumb, although it does change if you get into the obese categories. So those are some self-care techniques. You all in the audience are a little ahead of the game. You already know some general self-care pelvic health techniques. Let's touch a little on the organ support problems or the prolapses. This is more common in women. I already talked about that because we birth babies and organs shift already. But men experience it in the rectum and the urethra. On my pictures on the left here, you see a pretty normal anatomical orientation. You've got the bladder here, out the urethra, vagina, uterus, and then colon and rectum. And they're all above the pelvic floor, which my line right now is drawing a picture on the pelvic floor muscles that go from the tailbone to the pubic bone. They form the bottom sling or hammock-like structure. Remember those words, sling and hammock. We're going to use them later. And you could see all the organs are above. Go down into the second and the third picture, and you could see if the muscles are weak or there's been a lot of pressure or stretching from above. This is a bladder prolapse, and then this is a uterine prolapse. You can read my statistics. I think I'm just not going to read them one at a time. You can see that it happens a lot with women more than men, but can in men. You can see that if you have a prolapse, you can also have bladder control issues. The most common organ is the bladder. And then some people are more predisposed to this, and it all has to do with your collagen structure, your ligaments. If you're double jointed, really flexible, then the ligaments that hold your organs up, the muscles support them from below, but there's also ligaments holding them from above. If you have flexible ligaments, you might be more predisposed to this. So it does run in families and tends to be in the more flexible people. It does run in multiparous women, meaning the more children you have. High incidence after hysterectomy, and again, hysterectomy may be your cancer cure. It can be cultural, and again, that's the makeup of collagen. Culturally, genetically, different cultures have different collagen. Asian and Hispanic have a little less strong collagen. African Americans have strong collagen, so they might not be as predisposed to prolapsing organs. And then again, weak pelvic floor muscles. Those same Kegel exercises, if done correctly, definitely you want to support those organs from below, especially if the ligaments are stretched from above, and therapy can help you do that. If the organ is shifted significantly, they might do a surgery for it. Surgeries are pretty much try to be last-ditch effort for this. If an organ is too low, it could cause other problems. For example, it can usually obstruct your bladder or bowel from emptying. So you end up getting a lot of bladder infections, which can go up into the kidneys, which could go up into sepsis. And then if you have evacuation that can't get out because there's an organ shifted, that's going to move up into the system and cause bowel obstruction. So when someone's organ is so low that symptoms are moving up into the system and getting systemic, that's usually when they'll decide to do a surgery. But sometimes it can be a temporary thing, and you get strong enough and things are better. Sometimes you might need a support, and there's something called a pessary, and you see pictures of them here, and inside it's holding up the organs. This is a medical device, and it's like a brace for your organ. For example, if you had a bad knee and you stretched your ligaments, but you wanted to run again, your doctor would probably say, yeah, put this brace on and you could still run. Same thing here. Why chance doing a lot of physical activity that continues to push those organs down? Some ladies with an early prolapse can get away with strengthening the muscles through proper Kegels and then a support of one of these devices. These are medical devices. I don't fit them. Doctors have to fit them, usually gynecologists, urologists. And it is an art. So if you're asking about if this is something for you, ask your practitioner how much experience they have fitting, because there's different types for different organs. And there's, again, just like we talked about the gadgets, different size vaginal canals. So you need someone experienced. But sometimes just wearing that, it can be, a long-term thing or a temporary thing until you strengthen the muscles. And then again, learning the exercise and strengthening. If you need therapy, we can help. We're moving on into some of the sexual dysfunctions. This first slide is female, and then we've got one about male. And then we're going to get to our virtual Kegels to see how easy it is. And wow, so far it looks like it's only been a half an hour, so I'm on track. I hope everybody's hanging in there with me. Okay, we talked about pelvic health being bowel, bladder, and sexual health issues. So female sexual dysfunctions, and these are specific to, well, not specific, you can have them if you don't have cancer treatment, but these are the most common after cancer treatment. That painful intercourse called dyspareunia. That's the most common sexual dysfunction experienced by women after cancer treatment. And that cancer can be in the pelvis, or again, remember, highly connected to breast cancer because of the estrogen component. The number one reason that a woman would have painful vaginal intercourse is what's called vaginal atrophy, a true medical term. That's when the tissues and the cells change, and it usually occurs naturally after menopause, but hormone suppression can cause it more severe. The tissue becomes less pliable or stretchable, and then it causes friction irritation during intercourse. The number one reason for vaginal atrophy is the lack of estrogen. I'm going to go out on a limb here and just talk about something that's out of my scope of practice, but I know you all are probably hearing about these procedures. The laser vaginal rejuvenation procedures. One of the brand names is Mona Lisa Touch or something like that. What that's doing is it's taking a laser light, it's going into the vaginal tissue, giving a laser light to those tissues, which actually can stimulate the vaginal atrophy. So at the cellular level, it helps the cells increase circulation, rejuvenate. So if it's only vaginal dryness that you're experiencing, those procedures are great. They're not often covered by insurance. I think they're about $1,000 a piece. You get 3 of them, and then you get them once or twice a year. The ladies that I've worked with pain with intimacy, if their problem is vaginal dryness, that helps incredibly. But there are other reasons that women can have trouble with intercourse, and one of them is the muscles and scars from procedures. So some women who have the Mona Lisa, but they're still having difficulty with returning to intimacy, maybe it's scar tissue because that scar doesn't move and it's in the way. Or maybe these muscles, which muscles are the main guardians of the body. So if you're feeling pain in this area, if there's something that's causing, even if it's just the start of dryness and it's causing pain here, these muscles are going to tighten, and then that's going to be a kind of a vicious cycle. Well, then if the muscles aren't relaxed, well, that hurts. So that's why I can work with women after cancer if they have components of all 3, the vaginal atrophy, scar tissue, or muscle problems causing pain with intercourse. If a woman, think about it, if a woman has this problem after breast cancer and they focused everything up here, but all of a sudden they have problems down low and they don't know what's going on, or they haven't been educated, this problem can go on and on and on and cause a lot of emotional distress for the woman herself, feeling less of a woman, and then also in a relationship. So women after breast cancer need proper education in using lubricant and follow up with a skilled healthcare professional to take them through these quite intimate problems they're having. These in the picture are called vaginal dilators. They can be kind of scary looking, but sometimes for this problem they're indicated. If the tissue is scar and it needs to be stretched, or if you need to train the muscles to relax during penetration, sometimes these can be used. Women who get pelvic radiation to this area here, and that could be for a uterine cancer. The last time I gave this talk, there was a young woman in her 40s who had a rectal tumor, and she had to get radiation to the rectal tumor through the pelvis. Any woman who gets pelvic radiation for whatever cancer, your radiation oncologist should give you these things because they want you, after they radiate, remember there's a lot of swelling in the area, they want you to insert these so that the vaginal canal stays open and doesn't swell when all that radiation is occurring. So some women can get them from their radiation oncologist if they're going through pelvic radiation. If they have the problem and didn't have radiation, sometimes their gynecologist or gyn-onc will open a drawer and give them one of these in a box and say, here, use this. I guess it's emotional for me. If I had this problem, I would feel like I would want some help with how to use these things. I did tour a cancer center once, and I'm not going to say which one. And there I am. I work with women who use these. We go through what type, we go through how to use them, when to change the sizes, things like that. So I'm in this cancer center. I'm like, oh, can I see your vaginal dilators? Because I know you give those out. So the nurse takes me and she opens a drawer, cabinet, and there's multiple boxes, lots of boxes. And I'm looking, I'm seeing medium, medium, medium. And I'm like, oh, there's only one size here. And there's only one style, because there's tons. There's 50 kinds of dilators. Some are soft silicone, some are curved, some have tapers, some have handles. And I'm like, can I see your instructions? Like, what do you, when you give these medium sizes, what are the ladies supposed to do? And she's like, oh, we just have them read the box. And on the box is exactly what the radiation oncologists want you to do. Insert as far as possible for 10 minutes. And that's it. So I just thought it was kind of interesting that, you know, there are healthcare professionals like me that would help a woman, guide them through using this, instead of reading a box, getting the same size fits all, and using a hard plastic one when maybe a softer one might be what goes for you. So women, do know that a therapist like me can help guide you through that. It's a very emotional problem. I tell women, studies have been done that you're going to get your best effect with a female sexual dysfunction if you address the medical problem. Let the doctor give you the dilator. We'll decide if you need a different style or size. The physical, that's me, and then the emotional. So some women need to really dive deep into how they're feeling about themselves, and also with their partner and relationship wise. So this is a problem that can be overcome. It's just tricky, and I just want you all to know, you know, self-care, have the knowledge, everything that's out there to get better. So that's female sexual dysfunction. And then I have a little bit about males, because it's a totally different area. When, you know how I talked about when you're doing the pelvic floor contraction, you can't see it? Men have a little advantage. Women, it's all deep inside. Men, right here in the middle of the pelvic floor, the scrotal testicular sac comes down, okay? So you can see how if that scrotal sac is in the middle of the pelvic floor, if a man is doing a proper pelvic floor contraction and moving these muscles, he can just look down, and if he sees the testicular sac rise, that's his visual that he's getting the pelvic floor. So if the testicular sac rises and then the penis is on top, you're going to get a little rise with the penis. So I made this slide specifically because I think a lot of men, when they see that, they're like, ooh, you know, if I get stronger in these pelvic floor muscles, my erectile dysfunction will get better. And it's so totally complex that it's not that way. Remember, the pelvic floor muscles are more sexual in terms of orgasm, climax, and for men, that's ejaculation. Erection for men and for women is a nervous system phenomenon. So you have to have the nerves intact. Most prostate surgeries now are nerve sparing, so they'll try to keep away from injuring the nerves. But then many men have to wait for swelling to go down and the nerves to come out of shock for that nervous reflex to kick in. So erection, the nerves have to be intact, and then they stimulate, the nerves send signals for a circulatory event, blood flow into the penile tissue. What Kegels can do for erectile dysfunction, Kegels, when you pump your Kegel muscles, they can bring blood into the pelvis. So they're stimulating blood into this area, but then most men need to go on to get the blood flowing into the penis with penile rehab. It's kind of an interesting term, but it's a medical term. That's where vacuum pumps will be used to draw the blood into the penis, but Kegels will bring it to the pelvis. Sometimes men need injections, or again, the little blue pill that opens the blood vessels. I just wanted to make that clear because I don't want men to get, you know, misinformed that Kegels are what give you an erection. Just wanted to make that point. But let's go on to ejaculation and climax. It's a reflex. But guess what? We talked about it. The pelvic floor muscles assist in this action. Climax is a reflex contraction of those muscles. So if men can get past the erectile dysfunction, the stronger you get your pelvic floor muscles are, the stronger climax or ejaculatory function they will have. And that's the same for women too. So we both get a good effect from strong pelvic floor muscles in terms of climax. And I did put painful ejaculation in here. Again, the first problem males need to counteract is the erection problem. If they get past that, they could experience painful ejaculation. If that occurs specifically after cancer treatment, that's pretty much a cue to both the doctors and everyone involved that there's probably some scarring that's not moving during that event. And that can easily be taken care of learning a lot of scar massage. The men do it underneath that scrotal sac. Sometimes the doctors or urologists teach that, or the urological nurses. Sometimes I teach that. And then also, sometimes their pelvic floor muscles are too tight and painful. Maybe they've been scarred. Maybe they've been stiffened through radiation. So it's not all about strengthening the pelvic floor. Sometimes it's learning about relaxing the pelvic floor. Sometimes men in particular, and then women, both men and women with the sexual dysfunctions. So, okay, how we doing? I think this virtual Kegel trial that we're going to do is going to take maybe 5 to 10 minutes. That'll leave us a few minutes of question and answer. Remember, the studies show that I'm going to give you a brief verbal instruction, and right here on the screen you could probably see a handout that you might have seen from your doctor if they've recommended you to do Kegels. So 50% of you are going to get it and 50% won't. My goal is not to confuse or frustrate you. My goal is to bring awareness that we need to know more about this. We need to practice this. We need to talk about this. So that's my goal. This woman here, this is one of my favorite pictures. This is the way I teach Kegels. This was the front of a physical therapy magazine. Before I became what's called a pelvic health therapist, we were known as women's health, but we let the men in, so now we're pelvic health. But this woman is making connections to her core, and the pelvic floor is the bottom of the core and the diaphragm is the top. She's doing her Kegels because she's learning how the diaphragm and the pelvic floor work together. She's closing her eyes and becoming mindful. Can she make that connection from her mind all the way down to those muscles of her spinal cord? Did someone say something? Okay, so we're going to be mindful. And then we're also going to use visualization. Remember I said make a point to remember about that diamond you saw in the anatomy pictures. The muscles are between the bony diamond. So that's important visualization. And then also the muscles have 3 layers, 3 functions, and 3 kinds of contractions. You can have an isolated sphincter, that's circular muscle contraction. If you have a problem like with just the fecal incontinence, boy, that's the one I want to train. I want to isolate and make that one and that one only work. So when you're trying to learn how to isolate a sphincter, you could think about pursing your lips on a straw, squeezing your eyes real tight like you're blinking or winking, or pulling a drawstring tight. Because that visual, if you get that visual in your mind and down to the muscles, that will help you relearn. There's also a kind of contraction called a combined sphincter that I like to train for most incontinence. A combined sphincter goes from bottom to top as if you're holding gas, then zipping up. So you see a zipper there, a zipping up, a zipper from the tailbone to the pubic bone, kind of zipping up, getting all those sphincters. So a good image for that would be a zipper. Tailbone to pubic bone, zipping up, holding gas all the way up to the bladder. And then another image for that combined sphincter is a hammock. Remember I said these muscles form almost like a hammock or a sling? So your palm trees, I know this is weird, but it's gonna work. Your palm trees are your leg muscles, and these are muscles are between your legs. So to contract, you're starting at your tailbone and you're swinging your hammock forward up towards your bladder. And then as you relax those muscles, the hammock swings back between your legs. So that's another image. Remember the supportive function of these muscles. The supportive function, if you have a prolapse, I want to train you for this up and in, almost like a vacuum kind of contraction. So the jellyfish, what I put in there was actually a patient of mine, because she had her eyes closed and she was thinking and making these connections. And I said, what are you thinking about? What are you visualizing? And she said, a jellyfish. She had to describe that to me because she had seen a National Geographic show where they showed the jellyfish pulsing, bringing the tentacles up and in to surface. So anything like up and in of a jellyfish, turtle in a shell, if you've ever visualized how the turtle head goes up and inside and the shell is your bony frame. And then a very common, probably a 50 to 60-year-old image of learning that supportive function is the elevator. So here's the pelvic floor, and you're going up, 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 first floor, second floor, third floor, and the elevator shaft is that pelvic cavity. So just remember, imaging and visualizing and thinking is important. Sometimes your body will cheat. We're almost to our virtual trial. Sometimes your body will cheat, and here's the most common ways to cheat. We talked about breath holding. You could be trying so hard and you're pushing down and with your breath instead of letting those muscles come up, so you're fighting yourself. The way to tell that is if we have our hands on our chest and our belly and we're trying to kegel and we find that our chest isn't moving or our belly's not moving, then we can say, uh-oh, I better take a breath. And then if you're working from the back, like thinking about holding gas, the closest muscles are the buttocks. So if you feel a buttock squeeze and your hips rise or you raise up in your chair, that's a dead giveaway that you're probably using buttocks and not pelvic floor. As you pull those muscles forward, like holding gas, then forward holding urine, as you come forward here, more towards the bladder, you may feel your groins tense. So when we do our virtual trial, if you start feeling your knees roll together and your groins tensing, and you do your Kegels that way, your pelvic floor is not going to get strong. Then the abdominals. We are going to have one hand on our belly, and it is okay to do a little abdominals because the pelvic floor and the abdominals work together to hold our spine still as our core. But if somebody's like overworked their abs, they've done a lot of sit-ups and they're crunching, I'm going to do my Kegels, and they crunch, and their stomach muscles are too strong over weak pelvic floor muscles, again, that could be too much from above without a lot of strength from below, and that could make things worse. So now that we know tips and tricks, let's go back to standing up. You all can see me. Just stand up and take a break because we're almost near the end. Take a stretch. Kind of move things around. Okay. And then take your hands and put them on the bottom middle part of your buttocks, just where the butt crease ends and the legs begin. And start just gently like you're going to start to sit down, like a mini squat. And you're going to feel, usually in your palms, you're going to feel a hard bone, which is your sit bone. So you're starting to kind of squat and getting into that chair. See if you can't put those your palms on those sit bones as you start to sit down, and then go ahead and continue sitting down. So now, yes, you're sitting on your hands. I hope that's okay for everyone. And try to shift side to side, and you'll feel those bones go from your left hand to your right hand. Again, try to aim them to be in the palms. So then that means your fingertips and your fingers themselves can curl underneath your sit bones, because that's what those bones you feel side to side, and your fingertips will be on the pelvic floor. You're not in the midline. The midline is the rectum, vaginal, urethral, but you're in that soft, squishy part between the sit bones. Try now without a lot of coaching. Just try like you're holding gas or holding urine. Some of you may feel a tension, something tensing. If you're strong enough, you may feel the tissues lift away from your fingertips. You may feel like a door's closing or your sit bones coming together. If you feel something, you've got pelvic floor, but it can always get stronger. Now, if you're doing that and you feel your butt cheeks and you lift in your chair, you feel your round butt cheeks come into your hand, you're definitely cheating. And then if you're trying that, just holding gas, holding urine, and kind of pay attention, are my knees rolling? Am I tensing my knees? Then you're using your groins, okay? So we're almost in the proper position to practice our virtual Kegel. We've gone side to side. Get a happy medium so that you've got pretty much equal weight on both sit bones, okay? So you've equalized yourself side to side. Now go between a sag and an arch. Go between a slump and a perch, a slump and a perch, sag, arch. Okay, when you sag, you'll feel pressure on your tailbone, and that shouldn't feel good. That's going to make it hard to do a complete contraction because you're squishing that back part. If you arch your back and perch, that's going to put too much pressure in the front, and that's going to make it hard for those muscles to work. So just like we got the happy medium side to side on the sit bones, on our palms, try to go between arch and sag and find the happy medium, okay? Because what you're doing, lining your sit bones and your pelvic tilt as even as possible, is you're creating that nice bony diamond. You're giving room for that bony diamond to work as best possible. Otherwise, the muscles are going to be squashed, okay? So now that you feel like you're pretty even side to side and forward and back, close down your eyes, put one hand on your chest, one hand on your belly. Just tune into your breathing. Some of us are mostly chest breathers. Your hand on your chest will rise. Some of us are more belly breathers, should have a little bit of both. Just pay attention. And then notice, can you make, when you take your inhale, can you make your belly rise more? Almost like a deep belly breath. Because technically, physiologically, when you take a deeper belly breath, that increases abdominal pressure. Some ladies or men will actually leak the deeper they breathe. So I'm hoping that's not happening to anyone. But kind of what I want you to feel is, as you take a deep belly breath, can you feel the pressure that goes down into the pelvis? So why would you want to contract those muscles if you're already taking in a deep breath and putting pressure on them? Let's try it. Take a deep breath in and hold your breath. And then try to do that same, what you thought was a Kegel that we practiced earlier. It should feel like, you know what? It hardly moves. There's pressure on it. I don't want to be doing a Kegel holding my breath. Let that air out. Okay. We're going to try the next, a Kegel on an exhale. And I'm hoping with your eyes closed, taking your mind's eye down to that pelvic diamond, I'm hoping you're all going to feel that if you contract your pelvic floor when you exhale, open your mouth, actually make a sound, shh, ha, or shh. You're going to feel those muscles more easily rise and kick in. So take a breath in, and then on your exhale, open your mouth, make a sound, ha, shh, and try to pull in as if you're holding gas, holding urine. And my hopes are, I'll take a poll when we get to the Q&A, that most people will feel that it's easier. You might be stronger on an exhale because you're learning proper control and proper contraction and sequencing of those muscles, okay? Okay, from here on out, we're only going to do our Kegel contraction on our exhale because we probably felt or figured out that it's easier. If we're holding our breath or bearing down, we're fighting our pelvic muscles. We're pushing down on them. So on your next breath in, get ready for your exhale. open mouth, make a sound, and do that isolated sphincter as if you're pursing your lips or pulling a drawstring. Hone in, can you just find, say, the anal sphincter? Can you make that anal wink just there and nowhere else? Okay. Take another breath in. On each of your exhales, let's try this 1 or 2 more times. See if you can isolate and visualize. Can I isolate? Can I just do that anal wink? If you had fecal incontinence, that's all you'd want to practice. If you feel yourself lifting in your chair, it's probably buttocks. Tune in with your knees. Make sure you're still breathing. It's very hard to isolate. That's like one of the hardest things to do. So I'm not even getting it, so don't worry. Okay. We're going to try that combined sphincter where we go either like the zipper or this hammock. So get those visualizations. Eyes are closed. We're going to do it on your next exhale. Open mouth, make a sound, and zip up as if you're holding gas in the back. Draw forward, swing your hammock between your legs towards the bladder. Continue to breathe, continue to hold, and then unzip, let that hammock swing back. So that's getting all those sphincters. If you had urge incontinence, that would be good to have them all closing down. If you had fecal incontinence, you would want to focus on the anal isolated. We're almost through. Our last virtual Kegel is we're going to focus on that lifting function. So get in your mind's eye, either any image. The images were the jellyfish surfacing, the turtle in the shell, or the elevator going up and in. Actually, you can also use sucking on a straw. We did pursing our lips on a straw for the isolated sphincter, but if you visualize sucking on a straw up and in, that will get you. So get ready with an inhale, because on your next exhale, open your mouth, make a sound, and then visualize whatever you're doing, lifting up and in. Maybe your elevator's going to the first floor, second floor, turtle in the shell, jellyfish surfacing. Can you maintain that up and in, but continue to breathe high, hold low. Some people lose it the minute they take a breath, and release. Okay, that's a lot of mental work. And again, I don't mean to confuse you or frustrate you. I just want to give you an introduction to how important it is to learn this and focus, because a lot of people say Kegels won't help me. But if you're not doing them correctly, or you've never been coached or learned the anatomy and how these muscles work, you're at a disadvantage. So everybody in the audience, you're at a greater advantage just with that little frustrating virtual exercise. I am done. We have some time for questions.